Assalamu alaikum. I'm Dr. Rose. I will present you today's urology lecture. My topic is principles of urological surgery. After this presentation, we will briefly learn about the following objectives: operative evaluation, surgical testing, operative cardiovascular evaluation, pulmonary evaluation, hepatology evaluation, special populations, preparation for surgery, and intraoperative management. We will start with preoperative evaluation. The acuity of surgical patients is increasing as the population ages and as patients present with more significant comorbidities. The urological surgeon is responsible for ensuring that the patient has been thoroughly evaluated by the other physicians and the healthcare team arrives in and leaves the operating room in the most optimized medical conditions. The pre-operative use of appropriate medical specialist consultations not only result in improved patient safety and outcomes, but will also avoid the need for unnecessary cancer surgeries resulting from the inadequacy of medical optimization. The goal of pre-surgical testing is to identify an undiagnosed comorbidity, an untreated pre-existing medical problem, or a significant exacerbation of existing comorbid illness that may affect operative course or outcome. Operative evaluation should be individualized on the basis of age, history, physical examination, findings, and the surgical procedure to be performed. Any woman of childbearing age, unless the ovaries or uterus have been previously surgically removed, must undergo a urine pregnancy test on the morning of surgery. The ECG should be obtained from patients older than 40 years of age or those with history of cardiac disease. Most common pre-surgical testing includes CBC, basic metabolic panel, ECG, ARH blood typing, and antibody screening, and chest X-ray. American Society of Anesthesiologists classifications and risk. The goal of this classification system is to assess the overall physical status of the patient before surgery, and although quite subjective, it remains a significant independent predictor of mortality. It includes ASA classification, governance criteria, and cardiac risk index. ASA classification. It is divided into 6 classes. ASA 1 is a normal healthy patient, healthy, non-smoking, no use. ASA 2, a patient with mild systemic disease. ASA 3, a patient with severe systemic disease. Substantial functional limitation, one or more moderate to severe diseases. Example includes metabolic control, diabetes mellitus or hypertension, COPD, BMI greater than or equal to 40, ESRD, CVA, thyroid, ischemia, disease. ASA 4, a patient with severe systemic disease that is a constant threat to life, which includes a recent MI, CVA, TIA, chronic artery disease. ASA 5, a moribund patient who is not expected to survive without the operation. Example includes ruptured abdominal thoracic aneurysm, massive trauma, intracranial blood with mass effect ischemic movement in the face of significant cardiac pathology or multiple organ or system dysfunction. ASA 6, a declared blind patient whose organs are being removed for donor purposes. There is cardiac risk index. It's being divided with points. Risk factors: third heart sign, road GP, 11 points, recent MI within 6 months, 10, rhythm other than sinus, or greater than 5 points, or atrial contractions, 7, greater than 5 to mature ventricular contractions, 7, age greater than 75 points, emergency operations, 4 points, poor general health condition, 3 points, intrathoracic, intraperitoneal, or aortic surgery, 3 points. Sound aortic stenosis, 3 points. Total score is 53. This index. Risk factors: history of ischemic heart disease, 1 point, high risk Type of surgery, 1 point. History of congestive heart failure, 1 point. Sermon, 1 point. Insulin, 1 point. Appropriate serum protein greater than 2 is 1 point. Risk of major cardiac events is divided by cardiac requires classic classification and risk. Class 1, which is 0, a risk is 0.4%. Class 2, 0.9%. Class 3, 6.6. And class 4 and above, 11% risk of major cardiac events. Now, radiocardiac evaluation consists of initial history, physical examination, ECG, attempts to identify potential serious cardiac disorders such as coronary artery disease, heart failure, symptomatic arrhythmias, pacemaker or implantable defibrillator, and a history of orthostatic hypotension. The American College of Cardiology and American Heart Association recently collaborated to develop guidelines regarding cardiac evaluation before surgery, which includes 3 categories of clinical risk predictors, which includes clinical markers, functional capacity, and subject-specific risk. Clinical markers denote first general medical or cardiac evaluation depends on patients' comorbid conditions and overall qualitative risk. It is divided into major clinical predictors, intermediate predictors, and minor predictors. In major clinical predictors, acute MR less than 7 days previously, unstable angina, diagnosis of any ischemic burden by clinical symptoms or non-invasive testing, decompensated heart failure, significant arrhythmias, and severe valvular disease. While in intermediate predictors, mild angina, previous MI history or pathological key goals and ECG, compensated heart failure, diabetes or renal insufficiency, creatinine greater than 2 milligram per deciliter. Minor predictors, advanced age, abnormal ECG, rhythm other than sinus, history of stroke, and uncontrolled systemic hypertension. Functional capacity. Functional capacity or one's ability to meet aerobic demands for a specific activity is quantified as metabolic equivalents of the task. This simple measurement continues to be an easy and inexpensive method to determine patients' cardiopulmonary functional capacity. The activity status index, which has been validated in several studies, allows the physician to easily determine a patient's functional capacity. This is Duke Activity Status Index. Question number 1. Its scores are only given for yes replies. Take care of yourself, that is eat, dress, bath, or use the toilet is 2.75. Walk indoors such as around your house 1.75. Walk a block or two on level ground 2.75. Climb a flight of stairs or walk up a hill 5.5. Run a short distance 8 points. Do light work around the house like dusting or washing dishes 2.75. The student is the more physically active a person is according to set of activities of daily living. Surgery specific cardiac risks. Type of surgery and the degree of hemodynamic stress are two important factors that determine the surgery specific cardiac risks. That can be stratified into high, intermediate, and low risk procedures. High risk procedures. It involves major emergent surgeries, increased operative time, and large fluid shift or blood loss. Intermediate risk procedures, intraperitoneal surgeries, laparoscopic surgeries, robot-assisted laparoscopic surgeries, while low risk procedures include endoscopic surgeries and superficial surgeries. Evaluation. Pulmonary evaluation is important in all urologic procedures, but critical in those involving the thoracic or abdominal cavities. It is prudent to consider pulmonary functional assessment in patients who have significant underlying pulmonary disorders, significant smoking history, or overt pulmonary symptoms. Pulmonary function test includes forced expiratory volume of forced vagal capacity and diffusing capacity of carbon monoxide are quite easily performed preoperatively. Smokers have a four-fold increased risk of postoperative pulmonary morbidity and as high as a tenfold higher mortality. There are risk factors, specific risk factors, and general risk factors. Specific risk factors include COPD, smoking, non-operative gluten production, dyspnea, obstructive sleep apnea. While general risk factors include increased age, low serum albumin, obesity, impaired sensorium, history of stroke, invalidity, acute respiratory failure, chronic steroid use. Evaluation. Survival of patients with advanced liver disease has improved over the past decade. The surgery is being performed more frequently in these patients. Patients should be identified and evaluated before surgery. The patient should be questioned about timing of diagnosis and precipitating factors. On physical examination, there will be jaundice or scleral icterus, lucid, pulmonary arrhythmia, spider angioma, and clubbing or indicates hepatic dysfunction. Severe manifestation includes abdominal distension, encephalopathy, astrocytosis, ataxia. The patient should be questioned about timing of diagnosis and precipitating factors. On physical examination, there will be jaundice or scleral icterus, capitulocin, Palmer's edema. The use of child classification in MERD score offers a reasonable estimation. The MERD score is perhaps a more accurate assessment of perioperative mortality in patients with hepatic dysfunction. Now we will discuss specific populations one by one. Elderly population, special physiological, pharmacological, and psychological needs. A unique set of healthcare challenges encountered in these patients. Studies suggest that independent of comorbidities, perhaps the elderly patient cannot meet the increased functional demands required during the perioperative and postoperative periods. Morbid obesity. With the rising incidence of obesity, one must carefully weigh and balance the risk associated with any surgical procedure with the natural history of the disease when deciding the optimal time of the surgery in morbidly patients. It is estimated that patients with a BMI of 45 or higher will lose anywhere from 8 to 13 years of life expectancy. Obesity is the risk factor for postoperative wound infections, and when appropriate laparoscopic surgery should be considered. Pregnancy. Urological surgery in the pregnant woman is most commonly related to the management of renal colic and urinary tract stone. The fetus is at the highest risk from radiation exposure from the pre-implantation period to approximately 15 weeks of gestation. Surgical procedure should be delayed, if at all possible, until the baby is mature enough for delivery, unless significant harm to the mother or fetus will result. Semi-elective procedure should be delayed until after the first trimester. Second trimester is the safest time to perform surgery because organ system differentiation has occurred and there is almost no risk for anesthetic-induced malformation or spontaneous abortion. Postoperative trauma is best managed with narcotic analgesics because they have not been shown to cause birth defects in humans when used in normal doses. Nutritional status. Malnutrition comprises host defenses and increase the risk for perioperative morbidity and mortality. The preoperative evaluation and classification of the patient's nutritional status typically consists of an assessment of any recent weight loss and measurement of lab values such as lymphocyte count and serum albumin. TPN and enteral nutrition are the methods for nutrition build-up. For surgery, it includes management of medication, optimization of comorbid illness. It is important in improving surgical outcomes and reducing perioperative morbidity and mortality. Smoking must be discontinued at least 8 weeks before surgery to achieve risk reduction, and patients who have ceased smoking for more than 6 months have a pulmonary morbidity comparable with that of a non-smoker. Hyperglycemia can lead to impaired wound healing and a higher incidence of infection. Non-insulin-dependent diabetic may lead to discontinuing long-acting hypoglycemics because of intraoperative hypoglycemia. Patients with either hyperthyroidism or hypothyroidism should be evaluated by an endocrinologist. The surgery should be deferred until a euthyroid state has been achieved of the patient. Antithrombotic therapy. Urologists must carefully consider and balance the risks and benefits of interruption of chronic anticoagulation to determine best course of perioperative management of these medications. The pharmacological half-life of warfarin is 36 to 42 hours, and therefore most guidelines recommend cessation of therapy 5 days before surgery to ensure an INR less than 1.5. This is a chart of risk stratification of arterial or venous thrombotic events in patients of anticoagulation therapy. High risk in high risk mitral valve prosthesis will develop diabetes aortic valve prosthesis, recent within 6 months stroke or transient ischemic attacks. Child score of 5 or 6 or recent VT, severe thrombophilia, deficiency of protein C, protein S, or antitropin moderate risk group, bilateral valve prosthesis, and none of the following: atrial fibrillation, prior stroke or transient ischemia attack, CHAD scores of 3 or 4, a venous thrombotic event within the past 3 to 12 months. In low high risk group, bilateral valve prosthesis without atrial fibrillation and no other risk factors of stroke, CHAD scores of 0 or 2, and no other stroke or transient ischemic attacks. Single VT occurred in 12 months and no other risk factors. Better preparation. Since antibiotics were first shown to reduce infectious complications in GI surgery, mechanical and antibiotic bowel preparation has been a mainstay of urological surgery in the intestinal segments. The disadvantage of oral antibiotic preparation is primarily related to increased incidence of pseudomembranous colitis secondary to Clostridium difficile. Antibiotics covering aerobic and anaerobic bacteria delivered orally or intravenously before elective colorectal surgeries reduce the risk of surgery wound infection by as much as 75%. Intraoperative management. Intraoperative management includes various aspects of patient's care during surgery, focusing on optimizing patient safety and outcomes. Some key components of intraoperative management includes anesthesia care, administering and monitoring anesthesia ensure proper pain management and patient comfort. Vital sign monitoring, continuously tracking patients' vital signs such as heart rate, blood pressure, oxygen saturation, and temperature. Fluid management, administering appropriate fluids and medications to maintain proper hydration and hemodynamic stability. Respiratory management, managing ventilation and oxygenation, including endotracheal intubation and mechanical ventilation if necessary. Cardiovascular management, monitoring and managing cardiac function, including blood pressure, cardiac output, arrhythmias management. Surgical site management, maintaining asepsis using appropriate surgical techniques and ensuring proper wound closure. Pain management, providing adequate analgesia and sedation to minimize patients' discomfort. Thermoregulation, maintaining optimal body temperature to prevent hypothermia or hyperthermia. Hemostasis, controlling bleeding, and ensuring adequate coagulation. The anesthesiologist, surgeon, and surgical team collaborate to ensure comprehensive intraoperative management while guiding patient safety and well-being. Lastly, we will discuss about management of the pheochromocytoma patients, preoperative management. Alpha-allergic blockade. Only goal in pheochromocytoma patients is to control blood pressure and prevent hypertensive crisis. Medication and selective alpha blockers such as fluoxetine or selective alpha-1 blockers like doxazosine or prazosin. Duration typically started 7 to 14 days before surgery. Titration. Doses gradually increase to maintain the blood pressure below 120/80 once daily. Side effects: worst postural hypertension and reflex tachycardia. Second drug is beta-adrenergic blockade. It's indicated after adequate alpha blockade. Beta blockers may be added if there is a significant tachycardia. Medication. Common choices include propranolol or metoprolol. Many initial beta blockers without prior alpha blockade as unopposed alpha adrenergic stimulation can worsen hypertension. Calcium channel blockers. If blood pressure is not adequately controlled with alpha blockers or if beta blockers are contraindicated, then use calcium channel blockers. Medication includes mifepristone or amlodipine, volume extension. Chronic alpha blockade can lead to organ depletion. Liver surgery taken intravenous fluids in the days leading up to surgery to expand intravascular volume. Main ways to prevent significant blood pressure drops after tumor removal. Monitoring blood pressure, frequent monitoring to ensure effective control. Electrolytes, regular checks, especially if diuretics are used. Few chromoscytomas can cause hyperglycemia, so glucose monitoring is essential. Thank you.